So, hello everyone, and welcome to ISHLT Pediatric webinar. I'm Friederike Danne, a pediatric cardiologist from Berlin, Germany, and today we are dealing with the exciting topic of rise of the resistance, what to do with the pediatric heart transplant candidate with elevated PVR. So let me hand over to my colleague David Peng to introduce the first speaker. David, please.
Hi, thanks so much for joining us. My name is Dave Peng. I'm a pediatric cardiologist from Ann Arbor, Michigan. I'm filling in for Neha Bansal. She has a sick child at home who is hopefully getting better. I'd like to introduce our first speaker, Dr. Mohan John, who is a pediatric cardiothoracic surgeon at Children's Healthcare of Atlanta and assistant professor at Emory University. He will be giving us an interesting case presentation. Dr. John?
Thank you, David. Can you see my slides? All right. Are my slides showing up on your screen?
Yes.
Okay. So we'll start off with a case presentation. Our patient is a 17-year-old with a Shone complex and a long history of interventions on the aortic and mitral valves. He had a balloon aortic valvuloplasty as a neonate, followed by repeated aortic and mitral valve replacements throughout childhood for recurrent stenoses. He developed increasing pulmonary hypertension and worsening right ventricular function and was then referred for heart transplant evaluation. Prosthetic valves were functioning well on echo, but RV function was severely depressed with a tricuspid regurgitation gradient of 90. On the CT, we can see the prosthetic valves and LV hypertrophy along with calcifications in the ventricular wall. Cath numbers at rest, the CVP was 18, PA pressures were 69 with a left atrial pressure of 35. That gives us a PVR of 15.6 at rest. With 100% oxygen and inhaled nitric oxide, the mean PA pressures came down to 58 and the LA pressures increased to 47. That gave us a PVR of 4.4 from 15.6. He was listed for heart transplant as there were really no good options for mechanical support in this setting, restrictive physiology and 2 mechanical valves. The patient waited for 25 days before a suitable donor organ became available. Orthotopic heart transplantation was performed with a standard bicable technique. Our ischemic time was 212 minutes, and we came off bypass with moderate inotropes and inhaled nitric oxide with good biventricular function. Unfortunately, inotropic support increased over the next 2 days with decline in ventricular function and ventricular arrhythmias. The patient was placed on central VA ECMO with an LV vent. LV function gradually improved, and that allowed us to convert to a Centrimag right ventricular assist device and close the chest. So because we closed the chest, we were able to extubate the patient 6 days later. He was supported on the RVAD for a total of 13 days before being decannulated. He did well subsequently and was discharged home on postoperative day 34 on 2 pulmonary vasodilator agents. Our patient has done well since transplant. We could wean him off his pulmonary vasodilators at 1 year. On his most recent echo, he has normal biventricular function, and his PVR on cath is 3.26. He's had no episodes of rejection. Thank you for your attention.
Great. Thank you very much for presenting. So are there any direct questions we should address right now, or should we rather discuss everything after all the presentations? Maybe we do it like this. So then we introduce the second speaker, who is Rachel Hopper. Dr. Hopper is a clinical professor for pediatric cardiology with a focus on pulmonary hypertension in Stanford. And she is speaking about post-transplant management of the heart recipient with elevated PVR. Please, Dr. Hopper.
Apologies. Technical difficulties there. Okay. Thank you. I'd like to thank the organizers for including me in this webinar. This is a topic that's near and dear to my heart, and something I've taken a little bit of a deep dive into recently. When we think about pulmonary hypertension, it's really a spectrum of disease, and this classification scheme was put forth by the most recent World Symposium of Pulmonary Hypertension last summer. And as you can see here, when we think about the spectrum, group 2 pulmonary hypertension, or PH related to left heart disease, is a unique category. And because this group is focused on adult disease, pediatrics is included, but the classification scheme is primarily driven by adult disease. There's a real focus on heart failure with preserved or reduced ejection fraction. But certainly we acknowledge cardiomyopathies, valvular heart disease, and congenital heart disease as contributors to this group 2 PH. So when we say group 2 PH, what do we mean exactly? Well, this starts in the bottom right corner here with left heart disease of really any etiology. This causes patients to have left atrial hypertension and a backward transmission of this pressure into the pulmonary vascular bed, of course, starting with the pulmonary veins, moving into the capillaries, and ultimately causing pulmonary hypertension by elevating the pulmonary artery pressure. Now, these patients have a normal pulmonary vascular resistance. They don't have pulmonary vascular disease, but they do have PH. And I like to think of this really as the traffic jam effect. Everything's just backed up. But when patients sit with this traffic jam effect over time, there's progressive remodeling of the pulmonary arterial bed with medial hypertrophy and intimal thickening. And over time, this increases pulmonary vascular disease, and then patients end up with what we call the combined pre and post capillary PH, where they may still have the traffic jam effect and that high left-sided pressure, but now they also have elevated pulmonary vascular resistance. And this becomes a very challenging condition to treat. So what do we know about this problem of high PVR in children with left heart disease? Well, in the adult world, group 2 PH is the most common type of pulmonary hypertension because left-sided heart failure is so prevalent. But of course, we don't see this as much in children. But it's important because we know that an elevated pulmonary vascular resistance can be a contraindication to heart transplant, given the risk that this high afterload can impart to this newly transplanted right ventricle, right? We don't want to implant a heart and then see right-sided heart failure. So hemodynamic assessment by cardiac catheterization is typically part of our evaluation for heart transplant, often with acute vasoreactivity testing, and we'll talk about this a little bit more. And I know one of our leader speakers is going to talk about the difference between heart-lung versus heart transplant in terms of survival, but because there's a difference, we're really motivated to try to see if our patients are eligible for heart transplant when appropriate. Thankfully, we know that elevated pulmonary vascular resistance can be reversible with relief of left atrial hypertension, and it typically resolves after transplant, but there are really limited studies describing the clinical risk factors for elevated PVR, for knowing how long this will persist and how to address it optimally, and we really lack data in children. So this leads to a lot of practice heterogeneity and a lack of standardization from center to center. So as I mentioned, I've gone down a bit of a rabbit hole with this condition recently. Along with my colleague Karin Trend-Lundmark in Sweden, we led the effort to publish this recent AHA scientific statement. Whereas we got further into it, we realized that we really had more questions than answers. And so this schematic from our paper highlights, with all these question marks, areas of sort of lack of data and knowledge gaps in what we do. We really don't know all of the risk factors. We know that age is probably important. Severity and duration of left-sided heart disease is probably important, but we actually don't know the risk factors. And we also don't know what predicts reversibility. We have a lot of questions about hemodynamic assessment, and I'll go into this a little bit further, but really, when do we need a cath? The impact of factors like anesthesia, low cardiac output, some technical variations in protocol. So we'll talk a little bit more about that, but we have a lot of questions there. And also with acute vasoreactivity during the catheterization, how to do it, is it predictable? Is it predictive of longer term outcome in response to drug? What are the cutoffs we should use? And how often to reassess our kids. When we do find high PVR, how do we treat it? The role of ventricular assist device versus pulmonary vasodilator therapy or both. When do we reassess hemodynamics? And how do we best protect the right ventricle when we do, if and when we do list for heart transplant? So really a lot of questions and a lot of areas that are really ripe for further study. So in going over pre-transplant hemodynamic assessment, a cardiac cath is really important because obviously this is the only way we can differentiate that isolated post-capillary versus combined pre and post-capillary pH. But as I alluded to, we have some challenges. It can be hard to measure cardiac output in either a very low output state or with the presence of a ventricular assist device. There's some debate as to whether FIC or thermo is better. Sometimes we do both and get different answers. The impact of sedation and anesthesia when kids are sedated just doesn't reflect their true baseline, and we often see differences between echoes and hemodynamic assessment of PA pressures. And then this can be a very sick group of children. There is a procedural risk, and so how often and when to undertake a hemodynamic assessment can be a topic of a bit of debate. Also, a topic of debate is PVR the right metric? Some studies in adults, and I've found one small study in pediatrics suggesting that the diastolic transpulmonary pressure gradient may actually be more predictive of longer-term pulmonary vascular disease. And this is calculated from hemodynamic data by subtracting the wedge pressure from the diastolic pulmonary artery pressure. And the reason it may be better is that it's less sensitive to flow and some other variability. We talk a lot about acute vasoreactivity testing, and this comes from the pulmonary hypertension world. In patients with group 1 pH, we have very clear definitions of what makes a patient reactive. We have criteria that have been validated in studies, and this guides us in terms of when we use calcium channel blocker therapies in these patients. But AVT in group 2 pH is a different ballgame. We actually don't know exactly which agents to use, some like nitric oxide, plus or minus oxygen, nitroprusside. We don't actually have clear criteria that are validated on what constitutes a positive response. And this procedure can be risky, right? In patients who have left atrial hypertension, we can cause acute pulmonary edema by unmasking diastolic dysfunction. And we don't actually know how high is too high for wedge pressure in terms of performing this maneuver. It can help us potentially show which patients are reactive, who may respond to therapies and may be heart transplant candidates, but it's a little bit of a murky area in terms of safety and benefit. So where does all this come from? Well, we looked back and first found in 1993 this cutoff published by this 24th Bethesda conference in terms of transplant exclusion criteria. And they described this irreversible high pulmonary vascular resistance and defined it as being above 6 Wood units or 3 after treatment with vasodilators as being sort of set in stone based on a few studies in adults. And in the text here on the right, they note that vasoreactivity testing is important, and they give a number of different agents that were used at the time. And this is where we saw this definition of a PVR that decreases by 50%. As being potentially acceptable for heart transplant. But they don't actually cite any sources, and as far as I could tell, this wasn't actually based on any specific data. So what other data do we have? Well, this table's from our scientific statement, and I know it's a busy slide, but really the point is to show you the green are studies where PVR was not associated with post-transplant mortality, and these are all pediatric studies. The red it marks studies that were associated with mortality with high PVR. As you can see, it's all over the map. So they're listed sort of in order of year of publication, and potentially more kind of positive studies later on, but it's really all over the map. It's not a consistent association between elevated PVR and post-heart transplant outcomes in children. Many of the studies, as you see in this column here, did not include whether or not patients were reactive to acute vasoreactivity testing. And most of the studies don't actually include whether or not pH therapies were used in the populations, because often that data is not collected in transplant databases. The studies, as you can see in this other column here, use different cutoffs for PVR or transpulmonary gradient. And two different studies undertook an ROC analysis and came up with two different results. One showed a PVR of above 9 as a cutoff, and one came up with a PVR of around 3.5 as a cutoff. In the studies that did show an increased risk of post-transplant mortality with high PVR, it's unclear in those studies if the mortality was actually due to pulmonary hypertension and acute right heart failure. So this led us to wonder, could elevated PVR just be a surrogate for sicker kids? Are these patients who have longer standing heart failure, potentially more related risk factors? And in this 2008 paper from Ryan Davies and colleagues, they actually looked at multiple high-risk clinical indicators and found that the presence of more high-risk factors was associated with poor outcome post-transplant, and that kind of makes sense. So what are people doing now? Well, Karin and I conducted a survey a couple years ago that was answered by a number of respondents, almost 50 from 39 different centers in 16 countries. And about half of our respondents reported using a PVR cutoff at their center. And as you can see from graph A here, most people use a cutoff of 6. But different from that initial Bethesda criteria, they actually use a 6 post-acute vasodilator testing. So most people said, well, if they do use the cutoff, if they can get the PVR 6 or lower, then they would transplant. And most people told us that they did perform acute vasoreactivity testing for their patients. Now, interestingly, when we asked people, okay, so what's the highest PVR you've ever transplanted? You can see many are above that cutoff, either at baseline or post-AVT. Many people are transplanting kids with higher PVRs. And we asked about what were the indications for pulmonary vasodilator use. Most people said to help protect the right ventricle, to minimize RV afterload or avoid an RVAD, and also to improve transplant candidacy. And then when we asked which pulmonary vasodilators people were using in this population, you can see with and without LVAD, there was a big difference. So without LVAD in the black, there's a reasonably high percentage of people who said they would not use any pulmonary vasodilators at all. Those who do tended to use oxygen, nitric oxide, and PDE5 inhibitors, so sildenafil and tadalafil. And those percentages increased when an LVAD was in place, and this makes sense, knowing that the left heart is decompressed, less risk of pulmonary edema, and worsening left-sided pressures. So how do we approach pulmonary vasodilators pre-transplant? Well, in adults, the guidelines recommend against use of pulmonary vasodilators, and this is based on a number of studies that actually show either clinical worsening or no benefit at all. But we know that kids are different than adults. There's probably some benefit from placing an LVAD alone in our population. There's not a lot of studies in kids, but certainly some studies in adults have shown that PVR drops purely with placement of an LVAD. Pulmonary vasodilator use remains a bit controversial, of course, because of that risk of pulmonary edema and clinical worsening. But this study here on the left is quite a few years old now, but they showed pre-transplant use of sildenafil and bosentan with the post-transplant PVR normalizing. And this graph on the right is from our center. Seth Hollander led a study looking at our use of treprostinil pre-transplant in patients. And you can see we were able to improve the mean pulmonary artery pressure and the transpulmonary gradient without increasing the left atrial pressure. And most of these patients had improvement in their heart transplant symptoms. So I'll wrap up here by saying, group 2 PH really remains understudied in children with left heart disease, especially with respect to risk factors and management considerations. And I think it's important for us as pediatricians to better phenotype our patients. This has been sort of an effort in the World Symposium in the left heart adult disease group, but we can't treat a 1-year-old with Schoen's complex the same as a 17-year-old with restrictive cardiomyopathy. We need to have more tailored diagnostic and treatment approaches, and to really try to identify which PVR cutoffs, if any, are important. And this is only going to happen if we're able to band together and do prospective multi-center studies in this current era with VADs and vasodilator therapies to help us guide our practice and standardize the approach so that the care is equitable. And with that, I'll thank everyone, including my colleague, Dr. Karin Trant-Lundmark, and I'll turn it over to the next speaker. Thank you.
Thank you, Dr. Hopper. That was outstanding. We will go on to our next talk from Dr. Fawwaz Shah. He is a pediatric cardiothoracic surgeon at Children's Healthcare of Atlanta and assistant professor at Emory University. He also serves as the surgical director of the pediatric heart transplant program there. He will be speaking on post-transplant management of the heart recipient with elevated PVR. Thanks, Dr. Shah.
Thanks, David. Rachel, I think that was really a great segue into this. And I think hopefully today, in just this 10 minutes, I can share the story of 3 patients, all of whom are just a little bit different. And it kind of demonstrates the heterogeneity that you speak so well of in these patients, and just how that exists even within a single center. So these are 3 patients. Patient A is a 17-year-old with Shone complex, the one that was presented in the case presentation earlier. Patient B is a 13-year-old who had a ventricular septal defect and aortic coarctation, both of which were repaired as a young child, and then got lost to follow-up and then represented and had the PVR of 16 on initial cardiac cath when we first met her. And then patient C is a 15-year-old who had primary restrictive cardiomyopathy with no prior congenital heart disease, structurally normal heart, no previous surgeries. They were each managed just a little bit differently. And I think to speak to your point on transpulmonary gradients, I think despite having the high pulmonary vascular resistance index of BSA, the transpulmonary gradients were just around 10 for all of these patients. So the first patient had a PVR of 15.6, and with vasoreactivity testing, which for us includes 40 parts per million of inhaled nitric oxide and 100% FiO2, the PVR came down to 4.37. Patient B had a PVR, an initial PVRI of 16.4, and with vasoreactivity testing, this decreased to 7.5. And the third patient was managed for 4 weeks on milrinone, and then a repeat cath was obtained, at which time the PVR was 5.79. On the initial cardiac cath, the PVRI was 7.4 with initial vasoreactivity testing. And so oftentimes these kids are presented at our transplant multidisciplinary conference, and the question is basically, what do we do with them? I think patient A was a really good example. 3 years prior to being represented and me meeting him, he was told he was not a transplant candidate. At that time, the PVR was around 13. So basically he went home for 3 years and, waited at home. And then the general thought was, well, the team has changed. Let's represent him and see if there's something that we can offer. So each of them went to the operating room for orthotopic heart transplants. They were each managed a little differently, and I think we learned a little bit from each of them along the way. So the first patient, as was presented in the case report, came out of the OR and was doing okay, had good biventricular function, but then over the course of that first 48 hours, seemed to be more vasoplegic, developed some LV dysfunction, and so we ended up managing him in the intermediate period with ECMO until the LV recovered, and then Centromag on the right. Closed his chest and allow him to recover and rehabilitate after his transplant. The RVAD was removed at post-op day 13, and we'll go over some of the additional hemodynamic testing that we have for him. Patient B, after her heart transplant, there was a high, I had a high suspicion that she also was going to need an RVAD to support her. So I left her chest open, but after 72 hours, she had normal RV function, no TR, and was on low ventilator setting, so actually did not get an RVAD and just a delayed sternal closure, and she progressed really nicely. And then the third patient who ironically had the lowest PVR of the group, got a heart transplant, and then immediately after weaning from bypass had RV dysfunction and TR, and got a primary RVAD at that point with the chest closed and tunneled cannulas, and was able to have the RVAD explanted about 16 days post-transplant. So although we're all doing it in the in one center, that difference in management and the difference in the patients and the difference in the physiology of them, I think leads a little bit to just differing management. And I think some of those strategies are a lot reliant on just watching the patient and kind of understanding what they're doing in their immediate post-transplant course. We usually cath our patients at 4 weeks post-transplant for hemodynamics and biopsy. So this is reflective of their 4-week post-transplant cath, at which time none of them had their RVAD still in. But patient A had the pulmonary vascular resistance down to 10 Wood units per meter squared, and then patient B 9.2 and patient C 2.2. So already in the 4-week period, we started to see, after the RVAD was explanted, a drop in the pulmonary vascular resistance. Again, the transpulmonary gradients remained relatively low. They were all managed with tadalafil and ambrisentan. Typically, for the higher PVR patients, we'll start. They will all come out of the operating room with inhaled nitric oxide and 100% FiO2, which we'll try to quickly wean to 60% FiO2. And then they will, once extubated, get started on tadalafil, and then a second agent is usually added if the pulmonary vascular resistance remains high at the 4-week cath. So most of them were off of all of their pulmonary vascular resistance therapies by 1 year post-op, and we started to see much lower PVRs by 1 year post-transplant. And currently, so patient A is 3 years post-transplant, patient B 2 years post-transplant, and patient C is 1 year post-transplant. You can see the pulmonary vascular resistance has decreased to around 3 for patients A and B, and patient C it's 1.5. Each of them have had so far, thankfully, no episodes of rejection. They have a worse mild tricuspid regurgitation, largely normal RV and LV function for all patients. So I think that the things that we learned along the way and some of the strategies that we've adopted, I think you can, as you alluded to, I think left ventricular assist device support in the early period may be an approach for some patients. I think sometimes you're stuck with them having mechanical valves and many previous sternotomies, and it's not really clear whether an LVAD would lead to more sensitization and higher PRAs for them. So we've adopted a strategy of trying to support RV early post-transplant. We typically will use our cardiopulmonary bypass cannulas in the right atrium and pulmonary artery. And I know that across the US especially, there's some difference in the way we support patients with pulmonary hypertension, and some people favor a PA to LA strategy. I think one of the things that I've learned is that lowering the right atrial pressure and getting that CVP down is really critical to ensuring that their kidneys work and they're not on dialysis and things like that. And we've certainly, tried a PA to LA strategy in some patients, not post-transplant, but we've been stuck with them having higher right atrial pressures and having renal dysfunction as a result. So our strategy post-transplant for these patients has been right atrial and PA cannulation. We'll tunnel the cannula through anterior rectus sheath and then close the chest, which allows them to mobilize, get extubated, and aggressively rehab and progress in the period of time that they require the RVAD. We've typically used the Centromags, but in this era, I think we have to also acknowledge that what's available to your individual centers and what your team is comfortable with, I think, is really important in the success of these patients. And then I think, RV dysfunction, as we've talked about in other webinars and at the various forum at the ISHLT, often masquerades itself as vasoplegia and low SVR states. And this is something that I personally still struggle with, especially with the complex single ventricle patients post-transplant. So on a general level, I try to keep a mental note of how they behave in the operating room just to help guide the post heart transplant management. And if they're on full flow cardiopulmonary bypass, or I'm flowing at 125% of normal, and they're still struggling with mean arterial pressures, and I keep hearing the perfusionists asking for more phenylephrine, then I try to remember that for their postoperative management, because these vasoplegic patients can really be a challenge in of themselves, notwithstanding their higher PVRs and their RV dysfunction. The other things I look for are things like, is there torrential pulmonary venous return? Is the LA, so filled with blood that I'm having to use, 2 suckers to keep the LA not distended as the new heart is being sewn in. And then the other thing that I think is really important is I like to look at the pleural spaces, so widely open both pleural spaces, and sometimes there's just the entire pleura is just covered in these AVMs and in collaterals, and some of them can be quite large. In these patients who you're starting out with CVPs of 25, during the reentry, it's really not fun, because these collaterals bleed torrentially, and the resuscitation is extremely challenging because the patients have such great, diastolic dysfunction that they don't tolerate volume resuscitation very well in the immediate pre-transplant period. So if there's not any of these things that I notice in the operating room, and the patient gets back to the ICU, and then a few hours later the intensivist calls and the patient's really vasoplegic, I really worry a lot more about the RV, and we have a very low threshold for supporting it with an RVAT. In general, I think everyone worries about the RV. I think we still, despite all of what we've learned with myocardial protection, I still think that the RV is at risk in an ischemic heart and in immediate post-transplant state. But I think it's really important to try to understand how the patients are behaving in the operating room, and use that in the post-transplant period when you're trying to manage them. So my parting thoughts on this, I think, as Rachel, as you alluded to, we are at a point where we have to write the future of the management of these patients. I think there's no question that VADs can be helpful pre or post-transplant, and I think some of that may just be institutional choices, and when you feel more comfortable using the devices, and what the patients will allow you to use when they present to you. Overall, I think having a team invested in the success of the patients is critical to these challenging endeavors, and certainly at the ISHLT level, I think webinars such as this allow me to learn from all of you, and so I'm really anxious to know how others are doing this, and how through collaboration we can do this better. Really, there's not a vast plethora of data that we can draw from in the management of these patients. So I appreciate the opportunity to chat today and to be a part of this, and look forward to hearing a lot more of your comments and how you might do this differently and better.
Thank you very much. Then I'd like to introduce the last speaker, who is Dr. Rossa Brugha. I hope I got this right now with the pronunciation. Who is a consultant respiratory pediatrician at Gosh Hospital in London, UK, and also an associate professor at the Institute of Child Health. And he will speak to us about pediatric heart and lung transplantation in 2025. Please, Dr. Brugha.
Hi, thanks very much indeed. It's lovely of you to bring some lung people in to what feels a bit of a heart chat, although I can see the occasional friendly face. So if I say something wrong or something that's just about slightly mad rare medicine, then do forgive me. So I'm going to talk a bit about heart-lung transplantation and where it's at. So useful to go back and see where it all begins into the old school PDF versions of the New England Journal. 1982, I was born. And that's the first report of a large series of patients who are having successful treatment with heart and lung transplantation for pulmonary vascular disease. I think successful bilateral lung transplant on its own was only really kicking off later in that decade. So this is impressive stuff. And some big names on there like Norm Shumway. So heart and lung transplantation sort of peaks around the late 1980s with I think something like 100 transplants worldwide that year in the ISHLT registry. And that was predominantly for pulmonary vascular disease, so pulmonary hypertension, and then lots and lots of cystic fibrosis. And some of you will remember the concept of domino transplants, where people would get a heart and lung explanted, and then the heart would then be given to another heart recipient. That's now essentially been superseded by doing bilateral lung transplantations in patients with idiopathic pulmonary hypertension, and some of the heritable ones, SOX17, TBX4, BMPR2. Really because there's been a realization over the last couple of decades that the RV will recover once it's pushing against a normal circuit. There's some lovely long-term data from, I think, one of the French groups a couple of years ago in the journal, looking at how long it takes for the RV to remodel. So now we're left in a situation where heart-lung transplant is the best option in selected patients. Always be worried about that because they can see lots of variable behavior. Selected patients who have end-stage heart failure and lung failure. Now, those are a rare group. So I thought, oh, great, look, it's really nice. I've been invited by ISHLT to talk at a webinar. It's going to be lots of cardiologists. We'll wave the little blue team flag. Oh, there's really no information out there at all about heart and lung transplant in children. It doesn't get a mention at all in the 2023 registry report. It's not mentioned at all in 2019. At that point, it was late at night. I was feeling disappointed and I gave up and stopped going back further. But what I did dig out was some updated information from OPTN about how many lung transplants are being done. So many of you will know that we've got new super duper fantastic drugs for cystic fibrosis now. So those adolescents are not really being transplanted anymore. So overall numbers of lung transplants are falling. This is US data. There's a fall off with COVID, things picking up a little bit. I'm interested to find out what the 2024 data is when I catch up with you all in Boston. But digging down further into that, if you go deep into the tables of these reports, you can find, so 2018, 5 heart-lung transplants for kids. And 2023, there was just 1 out of the 31 done across the US. I don't know how many centers you have doing pediatric lung and heart-lung transplantation, but that's not a huge number of organs being transplanted. So we're talking niche stuff now. So whichever method you're using to do the PVR assessments, you do seem to be keeping these kids away from us. Just to come look at the UK data. We've got 2 centres in the UK. We're the bigger one, so this will be similar on the next slide. We've got 57 transplants across 10 years, so we're doing about 5 or 6 every year. We've done 3 in the last 10 years that are heart-lung, all first transplants. I can name those patients, but obviously then I'd have to go to prison. This is our data from Great Ormond Street. I haven't got the 2014 kid on there, but you can see we've done 1 heart-lung block in 2019 and another in 2023 on the background of about, 4, 5, 6 transplants here for lungs. And then the heart data here, because those boys like to show off and show how many they're doing in comparison. Now, our assessment process is interesting, and it's been really interesting to hear the speakers beforehand talking about, the key thing here. If you're in medicine and there's a debate about what's the right thing to do and everyone's doing different stuff, you're probably measuring different things in different ways. And the way that we measure PVR is by a combination of methods. So we're nervous about thermodilution, and we're concerned about, these small kids with low cardiac outputs who might have valvular disease and are shunting. We're worried about the Fick principle may not be completely right. That's the point where I get a bit nervous about saying things out loud like Fick principle to cardiologists, and I'm ready to be flamed at the end of the talk. But the way we pick up these kids is they've been referred to the heart transplant team, and the heart transplant team have done a bit of work, and then they turn around and say, we might need your help here. And what we're doing in the cath lab is velocity encoded phase contrast magnetic resonance. So we've got a cath lab that's got an MRI scanner in it, and we can use the MRI to guide where the catheter tips go. And then they use MR flow data plus Fick principle and pressure measurements to give us what we think is a much more accurate method of measuring pre and post vasodilator PVR, and this is described about, I think this paper's 2005, but we've been sort of working at that, not just for the kids who've got cardiac disease, but lots of our pulmonary hypertension patients, when we're deciding to list them for lung transplantation, we will use cardiac MR data because we're super nervous about putting these kids under general anesthesia for a cath, because I'm sure everyone has got stories in their heart of children who had a catheter and then found themselves in trouble. So we've got this hybrid approach that lets us measure stuff out. And I could have shown you the Bland-Altman plots, but it's a bit late in the day in Europe now to be talking about Bland-Altman plots. But here's the sort of line of equality, and then the correlation between using phase contrast MR PVR and what the FIC does. And you can see for some kids who've got wildly high FIC PVRs, that's actually giving much more sensible measurements on here in terms of what we're measuring with the phase contrast and FIC as a combined thing. Now, the other stuff that's probably outside of the continental US, that's a bit more of a worry for us, particularly is organ availability and waiting time. Looking back at that OPTN data, you can see your average wait time for a lung transplant for kids in 2023 is 90 days. The official UK data is whatever 3 times 365 is. It's about 1,000 days. Now, some of those are skewed by little people, but our public health system, which I won't go into in too much detail, but it involves the word socialism, seems to be better at preventing us getting donors than you guys do. So we've got to be quite concerned about wait times for patients. So we may list them a little bit earlier for transplant because we think you're going to be on the list for a while. But also in an acute organ shortage that we experience here, particularly for lung transplantations, the ethics of a kid who is going to get a heart-lung block compared to 2 people, one who would get a heart and one would get lungs, where we've got reasonable waitlist mortalities and long waitlists is a consideration. And the model we have of sort of beneficence, justice, the rights of the individual versus what is the best thing to do for society, and the utilitarian approach, the national need, that does have to come into our thinking over here. The other thing, of course, is how are you going to do, right? If you're under me, your 5-year survival is 66%. It's better than the international ISHLT data, but it's not the one you want to pick. If you can be under my mates, Craig, Jacob, Matt, and Mike, Rachel, Dilvir, and everyone else, then you've got a 10-year survival of 89%. So if I'm walking into the room, I'd much rather have the heart transplant and maybe roll the dice a bit on a PVR. And so we will debate what our cutoffs are, but using the MR scan, we will have a post cutoff of around 5 or 6, probably 5 Woods units, or sort of see how I think a patient's going to be. But that's all selected patients on an MDT case-by-case basis. I want to tell you a nice story. 11-year-old girl, she had a transplant a couple of years ago. You've seen her little blue bar. You've seen her in the NHS England data. She had a restrictive cardiomyopathy with a PVR of 12 Woods units, and her skin was falling off because she was so hypoperfused. It was awful. She got a heart and lung transplant in 2023. We can do lung volume reduction surgery at Great Ormond Street. So we trimmed down the right middle lobe and the lingula of a bigger donor to make the heart-lung block fit inside her chest cavity. She had some DSAs, she had pancreatitis, she had a pseudocyst, she had tachyarrhythmia, which needed ivabradine and a beta blocker. But otherwise, the care that we provide for the lung transplant patients and the heart-lung transplant patients is essentially the same, but I get the cardiologists to look at the ECGs of the heart-lung kids a bit closer, rather than me doing this with black spiders on a pink wallpaper. And we will give them statins, but we're not using aspirin or anything else. I've recently inherited a kid from the Far East who had a heart-lung transplant for TAPVD and pulmonary vein stenosis, and he came over on all sorts of exciting medicine. So it's not just hearts and caths where there's variable management both inside and outside the US. This is her FEV1 post-op as her chest gets better and her lungs, and her chest wall heals. She can do a better inspiration, so she can blow fantastic % predicted FEV1s. No videos of echoes in this talk, I'm sorry. And one of these siblings is my patient, bodyboarding. I'm showing the photo with permission. She's got a sister who's a similar age, and I've looked at this photo for ages, and I cannot for the life of me work out which is the kid who had the heart-lung transplant. And I think that's pretty cool. So in summary, this is a super rare procedure now in pediatrics. There's 2 kids on Earth walking around who had heart-lung transplants that I can find in 2023. These are small numbers. I would say to the lung people online, have a good chat to the cardiologists about how did you measure the PVR, and is there a way that you could do that in a different way, or how, what is your variability, what is your coefficient of variability for that test that we're basing massive decisions on. But also transplants can be very, very cool indeed and transform people's lives. Thank you very much.
Thank you so much, Dr. Brugha. That was fantastic. Now we have a little bit of time to have an open discussion and see if you all have questions for our esteemed panel. As you all think about that, feel free to put questions in the chat or also raise your hand, and we'd be happy to have you ask your questions. One question I had for you all, those are great success stories. Maybe starting with who have you all said no to for heart-only transplant, and kind of what for your centers, what did those patients look like, their hemodynamics, their diagnoses? Maybe give us an insight into how you all select for heart-only transplant. Kind of who have you said no to?
I can start. I think so these are the patients with the highest pulmonary vascular resistance that we have had the opportunity to kind of participate in their care in, which coincidentally, at least so far, has worked a little bit in our favor, despite more challenging postoperative courses. I think patients with higher transpulmonary gradients or known intrinsic lung disease are patients that give us more pause. And then the group of patients with who are failing Fontanes, for instance, which it can be an entire conference of itself. Those patients who I really struggle with deciphering whether they have intrinsic lung disease, high pulmonary vascular resistance, or hepatopulmonary syndrome, or a combination thereof when they have liver disease also. I think those ones are the ones that really are challenging for me. But in terms of the isolated high pulmonary vascular resistance patients and restrictive cardiomyopathies, these are the ones that we have had the highest PVR, so we've transplanted.
And Scott, you had your hand up. Did you have a question or a comment?
Yeah, more of a question. So in some situations, we end up with patients post-transplant that are having pulmonary hypertensive crises. And our standard, continuous flow RVADs, are not going to be super effective against these acute spikes in pulmonary hypertension. And so I'm wondering what strategies people have used in the patient who's having pulmonary hypertensive crises other than the standard ventilation and sedation paralysis.
We love prostacyclins. We do a lot of post-op prostacyclin use in patients where we're worried about the RV, and certainly have a low threshold to initiate them. Flow in is nice because it has such a short half-life. So we have a pretty low threshold for using that in anyone where we're concerned they're having significant pulmonary hypertensive crises or stress to the RV post-transplant.
Anyone using other mechanical support options besides ECMO? So anyone on the call that's used like a pulsatile pump rather than a continuous flow? Thank you.
Rachel, would you treat them with prostacyclins only, or would you rather start with PDE5 inhibitors quite early post-operative?
We use a lot of nitric in the post-op period. At our center, we don't use IV PDE5 inhibitors. So for an IV therapy, we tend to use prostacyclins.
Okay.
I think they work better anyway, but that's my own personal bias.
That's I think all three of the speakers kind of had a call to, standardize how we measure our group 2 pulmonary hypertension pre-transplant. So what are some suggestions? And we've been trying to fund a hybrid MRI cath suite for quite a while. We're still trying to raise that money, but what are some other ideas onto how to potentially standardize that measurement? Because it does seem like we're talking about apples and oranges and not necessarily the same thing.
Maybe I can comment on that. We recently had a patient, but this was a sort of bigger teenager who we put on a constant monitoring of PA pressure using this cardio-MEMS sensor. So, but this is not for the very acute one. This is more for chronic, like not to miss the right time to put him on the list or to put him on high urgency would be in our case. We found that quite effective, but this is a single case. And of course, this is not working for small children as it's technically not possible.
No, that's a great idea. Definitely, I think CardioMEMS, ambulatory PA pressure monitoring has a role in some of the future management of these patients. Rachel, are you using some of those for your PH kiddos?
We've done a few CardioMEMS in this population, which honestly sometimes they're helpful, sometimes they're not. Sometimes we get a CardioMEMS pressure reading that doesn't actually match up with the RV pressure estimate by echo, and then you're sort of left saying, well, which is actually the right answer. So in some scenarios, it's been a little more confusing than helpful, but it certainly is another data point. And as we, kind of learn more about the devices, we may end up using them more. In the near term, our center tends to rely heavily on PVR, but after kind of educating myself a little bit more in writing this statement, using some of these very simple, diastolic pressure indices that have been more well validated in the adult world is really something that would be easy for us to go back and look at, in larger pediatric populations to see if even some of those metrics may be more predictive and maybe more helpful and less flow dependent than PVR. It's always bothered me that, you can do vasoreactivity testing and lower the PVR by raising the wedge through the roof, and people think, oh, the PVR is so much better, but it's not a good thing. So we need metrics that are actually, I think, more helpful in terms of telling us should the patient be on vasodilators or not. I'm often telling fellows, oh, the PVR went down, but now the LA pressure is 35. Like, this is not a good thing, and this doesn't mean we use pulmonary vasodilators. But back on my soapbox, this is something that, in a perfect world, a number of us can band together and get data from multiple institutions, because there clearly are things that we're all doing the same way, but things that we're all doing differently. And I think there's a big potential here for us to learn from each other, but also maybe compare different approaches to see if there are, potentially some things that work better than others.
And how does that diastolic pressure gradient compare to kind of your typical PVR measurements? I know you alluded to it in the talk, but do you mind?
Yeah, I can only find one small study in children that actually showed that it was more associated with longer term outcomes than the PVR was. But there are a number of studies in adults, and my understanding is that a lot of the adult centers use these metrics more regularly than we do in children. So it's certainly something that would be worth exploring.
Absolutely. And the CardioMEMS does give you the more of the diastolic pressure too, which.
Yeah.
I have a question from a surgeon's perspective, I guess. Do you feel that any of the newer oral heart failure medications will be helpful in this patient subset? Do you think that any of them help in a restrictive patient with restrictive cardiomyopathy?
I do have my esteemed colleague, Dr. McCormick, on. I don't want to put her on the spot, but she helped use selexipag and others to bring down a just horrendously high PVR, I think close to 30. I don't know, Mandy, if you are at a point where you can speak to that.
I apologize. I'm mitigating consult questions. But yeah, Dave and I had a really tough patient, actually very reminiscent of, I think it was Dr. Shah's case reports about a Shone's patient with incredibly high PVR that seemed to be not totally mitigated at baseline. I think the kind of like original vasoreactivity went down to like, I don't know, from 22 to 15 or something like that. But we were able to inch in vasodilators, including oral prostacyclins over a period of years, and then ultimately got her hemodynamics down to a place where our transplant team felt like we were comfortable taking her forward. And she did have a little bit of RV dysfunction post-transplant, but we were able to salvage her and now is off, I think, everything but tadalafil.
Great, thank you.
And I think your question was also about some of the newer heart failure medications, right? I mean, I'm not a heart failure doc,
Correct.
but it seems like there's a lot of promise, at least from what I've heard in the adult literature. I think it's interesting that Vericiguat is a soluble guanylate cyclase stimulator that's now being used for heart failure, but we are familiar with its cousin Riociguat that's used for pulmonary arterial hypertension. Dave, I don't know if you or some of the others in the heart failure space have thoughts about some of these newer heart failure agents and how they might impact pulmonary vascular disease.
Thought I read somewhere that there's some evidence that Entresto also has some pulmonary vasodilatory effect as well. Definitely, we're starting up the Vericiguat trial, so it'll be interesting to see its effect on kids and the safety profile and whatnot. But that's I didn't really make that connection about the pH therapy as well. So that'll be really interesting, especially in our patients with elevated PVR.
David, when we were putting together this webinar with Neha, we thought it would be a really interesting topic for the webinar space. But I think from everybody's input today, I think it really provides us with an opportunity to collaborate and do something a lot bigger than just have a one-off webinar on this. And certainly we would be more than happy to participate in something like that. But certainly, hopefully, this is not an end, but a beginning for us in this space.
Oh, that's very well said, Fawwaz. And I think to Rachel's point, if we should definitely collaborate to learn more about the hemodynamics that we already have. And since there really is no solid way of doing this, we should try to agree on some evidence lacking consensus to guide our next steps. And I think we have a list of registrants, so we can definitely put out some calls as well. All right, any remaining questions? Okay. Thank you so much. This will all be available on YouTube, and also I think that will be posted pretty shortly after. So hope to see you all in Boston.
Yes. Thanks, and hope to see you soon.